We're supposed to start recording, and Alex got. Let's just make this thing famous. Do you have a name for this?
No, not yet.
Also want to know how come Brad's journal isn't making an appearance. You got full that fast?
I filled it, yeah.
This is the problem, folks.
Writes down everything about people's like sixth ancestors and how they're paying probably.
That's a giant journal.
Yeah, dude, that's huge.
Brad, send more. We need help.
Basically, like each page was like a week. 2 pages was a week. I can fill a ton.
Welcome back to episode 20 of the week in review. Talking to Harry Potter over here in his Wizard Book of Spells. You got Seth, you got me. Do you need some time to read through your book?
This is like at the restaurant. I'll just go last.
Okay, so while Alex is picking his case as we get ready to record. Oh, he's got his case.
So
He's
we're
talking
talking
about
highs
highs
and
and
lows.
lows.
Oh, we'll come to you last then. So we're going to do wins and losses, gutters and strikes, highs and lows, whatever we're going to call it, of the week, really quick. So what do you got?
Wins of the week. Are we doing wins and losses?
Yeah, you got to give one win, one loss.
Okay, I'll start with my loss. That way we end on a high note.
Okay.
So I would say my loss this week would be, and this might be for anyone who's like a young clinician, had a patient that came in, got treated, and basically resolved pretty much all the symptoms that he had. And then he, asked me how long I had been here. I think I've been here, 8 weeks now, 9 weeks or something like that. At that moment, he pretty much completely checked out, went to the front desk and said that he wanted to still schedule an appointment with another doc in the office to have a follow-up to have his stuff like seen again.
Yeah.
My win of the week is 3 days later he came back in, and Beau was the one who saw him because he wanted to see him. Beau found the same stuff that I had found, and then he's now back being my patient, and he was like, he apologized for when he stepped out of the room. He apologized for getting a second opinion, and he now trusts me with his care. So that's my wins and losses.
But you asked a question kind of not specifically off that, but I had another patient today that we were working on breathing, and give him the question framework because it's kind of on the same line of.
Yeah, mine was, I asked you earlier about whether you feel like patients question you if they questioned you a whole lot, like when you first started versus like now. Because I feel like whenever you're in the room talking about like breathing and pressurization, people are just like, yeah, that's like normal to be taking home. But it's like if I talk about that, they just ask me like the whys behind it. And I feel like I'm constantly explaining or talking all the time instead of just, you'll say like, you need to take this home. And they're like, yeah, sure. And then I'm like, you should take this home. And they'll be like, well, why should I take this home? And then you explain to them, and then they have like, an engineer has zero clue about a diaphragm and pelvic floor. And then you're just like, I just need to stop talking as is. And then they leave. And then it's like, you'll be like, yeah, I'm going to follow up with you probably for like 2 times next week. And then I'll get the question of, well, how long should I be coming here?
Mm-hmm.
Instead of just like, it's a normal treatment plan.
And my kind of 2 thoughts were, one, you can't fake the confidence behind what you're saying of just experience. Like you may think you do know, you're like, yeah, this is how this works. Like, this is, what I'm telling you is what we think to be true, but it's just not going to come off of 100%. Like you just haven't seen enough to like, there's a subconscious, like unknowing. The other thing is, like we said, the altered placebo perception of somebody's coming in to see me. It's been referred by somebody. They already expect something. So I think they're already like, yeah, I'll listen to this guy because somebody told me that he's great. And, they come in, they don't know who you are. They haven't heard of you. They come into our clinic, they may know who we are. And then we send them to you and they're like, so I think it was just simply, and that patient in particular had a bad previous experience with not a practitioner here, somebody else. So it has their guard up and it's just like, literally if asking a different way, like, who the fuck are you? Like, not, oh, you've only been 2 months. I think you could have worked here for 5 years. I think they still would ask the same question and maybe have the same response. Mm-hmm. Like Daniel's run into that, years of practice and stuff. So yeah, I think that is an apropos question. We're still giving you time, so make sure you're ready.
Princess over there.
My win was kind of outside of the clinic. I put up a post for my mom to find a practitioner in Fort Myers, Florida, that's like us. And it's my mom, so I'm going to be even more picky than if I was just sending any other patient out. And I'm going to be honest, I had a really tough time finding somebody that I thought was worth a damn. And this is no knock on them because they've done proved themselves. Even the person that I sent her to, I was just kind of like, it's the best I could find. And you don't know, I didn't talk to the person. I don't want to front load somebody with, hey, this is my mom. Make sure you do this stuff. Make sure you look for that. I just want them to do their thing. She went to him, had a fantastic experience. She's feeling a little better already. So that gives me confidence to, just kind of not think that like what we do is the only way to do it. And again, maybe their clinic is very similar, but it didn't seem like it. So it's kind of a win to know that like we do have other people out in the field that I never knew who this guy was that's doing really good work. So I think it's a win for the professional in general. I feel like I should start with losses, seeing on a positive, but my loss for this week, I would say honestly, the last patient that hate to do individual patient experiences, but a guy that I've been seeing, classic stenosis stuff, pain in his hip, he just ain't getting better. I mean, we've thrown pretty much everything at him. He's a very intelligent guy, great mover, really healthy for his age. Nothing's changing. And he even said today, he goes, I'm getting desperate because his biggest complaint is he can't sleep without his hip just killing him, waking him up. He's on hydrocodone. So you can be as good as you think you are, be all over what you think is going on, and still not get results for all sorts of reasons. But I even told him, I go, we're going to give this one more visit if nothing changes, because I don't think we pushed the needle at all. I think he was being nice. He was like, yeah, maybe it's better. And then we got to think of other options. The big loss is this guy's done about everything else already. So it's like, what is next? And that's the tough thing when you get to the end of a road, nothing's changing. And we're talking very functional mover, and the things that I would want to see functionally change will take time. And then that's going to have to be the conversation. Well, the next point of triage is not a referral for an epidural or whatever. It's going to be time doing the same stuff. And that's not what anybody wants to hear when they're like, I can't sleep at night. So that's going to maybe suck. So if you're out there, I don't know, make a little voodoo doll of that patient of mine and stick dry needles in his hip so he feels better or something. Come up with something?
Yeah, so my loss for the week, I would say I had a few people that I did this well with, and then I did one that I didn't. And it was like, came in with low back pain and then had a second complaint, and I tried to do too much. Tried to do too much at one time, and it didn't really make either of them better. So the next visit, I will not do that. I'll be like, hey, I just need to focus on this one thing, and then if we get to it, cool. But reassuring them that yes, I'm going to get to that. Just it might take a little longer than 20 minutes.
Yeah.
The win. So I saw, I guess this lady was technically Friday of last week, but I've seen her again this week. She's mid-30s, she's got neck pain that radiates down to her hand, and she had cervical fusion at 5/6 last year, or no, 2021. And she was like, yeah, it basically feels the same that it did when I had the fusion, or prior to having the fusion, which the fusion helped. She was like, I didn't have pain for a while, but then now it's back. She also had a lot of other kind of complicating factors. I could tell she had said she was taking some kind of antidepressant, she was very down, to she wasn't, didn't have high self-esteem. And so as we started talking, I tried to find her interest, we started talking, and then we literally did 30 chin retractions because she had no extension at all. And she got up and she was like, yeah, that doesn't hurt at all. She's like, I haven't felt this good in a long time. In my head, I was like, dude, if we just did 30 chin retractions, do you actually need a fusion in your neck? Now, I don't know if that's a win. I wish she would have had to have a fusion,
right?
Because she's not old, but still, I was just like, man, if you don't think that a little bit of movement is
Yeah.
helpful,
Win with kind of a loss, like
Yeah.
should you have a surgery? Yeah,
right?
but
Like
still
I wish she could have seen somebody like us like a long time ago.
But that doesn't that make you wonder too in that scenario? So where do you think the radicular is it like coming from like C6, C7 now, or
Right. Yeah.
like because it can't move that area, so that's just interesting that you're like, okay, I get afferent input, but
yeah.
I don't know. Interesting. Do you know what case you're doing?
Mm-hmm.
Start with your case on the ground.
There. Foot going up.
About time.
Okay. So today, talking about 4-year-old male, chronic bilateral Achilles pain associated with trail running. The right foot started about a year ago, and then the left one started about 2 months ago. It is worse in the morning. It takes the first few steps, and then at the beginning of his runs, pain usually decreases after 10 or 15 minutes. Pain's located medially and laterally, kind of near the insertion of the Achilles. Ibuprofen helps some, but doesn't get rid of his pain. And then in the last year, he's still continued to be able to run 20, 30 miles a week. He just usually runs slower than he was before. Sometimes notes that it radiates proximally, but otherwise just kind of stays there. And then had secondary complaint of right knee pain. It's just kind of random, started 2 weeks ago, 2 weeks prior to our first visit, when he was squatting down. He doesn't really do much outside of running, just runs. And then was feeling that on the medial aspect of his knee, of his right knee. So he's like, I obviously can continue running, but I just don't want to make whatever this is worse. And I'd like to run more, because he wants to run some like longer races in the near future. So on exam, top tier, he moved pretty well. Like he didn't have any painful movements. Dysfunctional, non-painful was single leg stance bilaterally, then right rotation and cervical flexion, which the single leg stance to me was kind of what we keyed in on mostly. Range of motion, the things that I noted for right knee was extension was limited and with pain, and then great toe extension bilaterally. Neuro, decreased patellar and Achilles reflex on the right side. And then palpation, T-spine extension restriction, and then midfoot bilaterally. So we've got functional audit, single leg stance, and then pain audits for the Achilles and the knee. The Achilles, just kind of palpating over the area, and then a soleus raise for pain audits. And then for the knee, right knee flexion, and then Thessaly's, which the knee flexion wasn't limited, which is pain. And I think I said that backwards on the knee extension. The knee extension wasn't painful, it was limited. The knee flexion was not limited, but painful. Got it, cool.
I think I understand.
Yeah. So that first visit, I tried to see like what we could do to change the balance. I think I'd done the half kneeling balance, and that was fine, both sides. So I was like, okay, we're gonna not go after the hips, go after the feet. Did some foot rolling, went back, checked the balance, and that was like way better. So okay, cool. And after doing that, his Achilles, like on palpation, was better. Same thing with the soleus raise. All right, cool. And then again, after talked about it in the wins and losses, I tried to talk about both. I tried to address both for the first visit. So maybe we would have done more on the foot, but I started going into the knee a little bit, and since the knee extension was limited but not painful, we went after just some knee extension glides on the right side. And again, made his knee feel better when we were doing squats. So that was those are the main two things I did for the visit that day, and then sent him home with the foot rolling and the extensions. with the plan of going after some of the foot stuff the next visit. So he comes back. He's had significant improvement in the Achilles pain. Was able to run. They're like, he also does he also does F3. That's what I was gonna say. He does do some stuff outside of running, but he just kind of does like cinder block workouts.
Bro workouts.
Yeah.
Some kind of workouts.
Yeah. So he covered like 3 miles doing their F3 workout that morning. Didn't really have any pain.
Did the cinder block workouts start with Chris Johnson, the PT, the running guy?
I have no idea.
Where do they get enough cinder blocks?
Dude, there's a ton.
Why cinder blocks though? It's not really that heavy. It's awkward.
What are they, probably like 20 pounds?
Maybe, but like,
Yeah, they are awkward for sure. I mean, I definitely wouldn't want to come with one on my shoulder.
They
get
keep
something back.
doing
Get
that. I
some
mean, we
rocks.
get patience out of it.
Yeah.
Keep cinder blocking.
It's true. So he only had pain like a little bit at the beginning of the runs. Not as long as prior. So our treatment that day, we're going more after the foot. Threw him in the hang stance, and then we worked through toe yoga, short foot, getting him to be able to
I think you mean toga.
yoga. Yeah. You should just we just need to change the name on the video and thumbnail of you and toga.
Or a big toe and a toga. Happy face.
Alex's book and a toga.
What?
Create a whole Instagram page for the book.
That way
Yeah.
it might get lost. Watch him just break down in the middle of his runs. It's gone.
Okay. Third visit, comes back, and again, some significant improvement in one Achilles versus the other. So previously it was like both were doing better, but I could still like kind of palpate on it, and it was pretty tender. Also, I don't know that I've seen this many of them, but it kind of looked like he had haggling deformity on both sides, which, I don't know how long that had been there. And so that day, we were still kind of working through loading through his big toe this time. So I had some big toe sits, and then we went into like bear hold. Also, I forgot to jump back. Right knee isn't bugging him anymore at all. We just literally did those extensions, and he was like, "Yeah, it's fine." So
Kinsey Miracle.
yeah. Then fourth visit, the first time I noted like change in single leg stance without doing anything that day. Like he came in, I checked his balance, and it was good on one side. I think the other side was like kind of iffy, but right leg was functional, not painful. And he's not really. Prior to, he had noticed some swelling. I didn't really see any swelling on that day when I saw him. He was like, "Yeah, sometimes after I run, like it feels like it's swollen." Wasn't feeling that anymore. He also ran hill repeats the previous weekend without any pain, which normally causes him pain, which you would kind of expect. And so he's doing the bear stuff. We progress it to more like a bear crawl. And then I wrote down that we worked on hip airplane, and I was trying to remember why we did that. Because in my first 3 notes, I had that hip range of motion was normal. And then the last note, I had that his right hip was limited internal rotation. And I was like, maybe I just didn't pick that up on the first few visits. Maybe it was limited and I just didn't feel it that way, but that's how I felt that day. So we went after that, and that like improved a lot after we just loaded the hip airplane.
Was that just a single leg stance was worse on?
Right.
Okay.
Well, they were both. I don't know which one was worse.
But the
right one
next
got.
time,
Sorry.
next time he came back in, you
Right
said
was
one
better.
got.
The right got better.
Okay.
Like the right was what was functional. The left was still kind of taking some time. But yeah, he I think his confidence in his ability to run, and it wasn't gonna be a problem. Like went up over the course of the trial of care.
Mm-hmm.
Because that was really, he just wanted to make sure that I'm not gonna hurt myself by continuing to run.
Mm-hmm.
So
Yeah, that was the main note that I made. That's I think a common theme that I wouldn't say I pay attention to more now, but like you just hear it a lot that people you're still going to help them, but a lot of people just want to know, am I going to get hurt?
Yeah.
And I think as soon as you can address that, not just to brush it off, but literally examine them and be like, it's not an injury or it's sub-threshold, or like, I think that there's probably a big placebo effect of just, oh, I'm good. Like, I'm not hurt. I think that's, I mean, literally had a lady that came in yesterday. That's all she really wanted.
Mm-hmm.
I mean, we improved range of motion in her knee and all this stuff. She's like, I'm going on 2 big trips just to make sure I'm not hurt. And then helped her. And I was like, hey, we can make your knee better than it was.
Mm-hmm.
So I just think that's a common thing, which you said, I think it built his confidence. I think having good exam skills will let you rule in, rule out injury really fast instead of just jumping into treatments.
Yeah.
And then even if somebody, like, say your treatment sucked, like, again, they go out and they move more, who's to say that them moving more because they're less fear avoidant and more confident. That's like the big catalyst effect. So I think that's important to address, and also knowing when they do have something that you need to pull the trigger on.
That's what I was curious to see, if it was actually gonna, I mean, the fact that he was able to start around 20-30 miles a week was.
Achilles are tough to, like, I mean, if it's red hot and swollen, I
Right.
think you're like, well, we're going to shut down or chill. But I think they're hard because, you know, I don't know. Then you have to kind of go, well, how bad it hurt you? Do you start limping? Do you alter gait mechanics? Right. Which I think is a good rule of thumb for running. Like, if you start altering mechanics, like, you're done. Yeah, Achilles can be tough. Yeah. It's not like I mean, it is a true orthopedic injury, but it's, varied, I guess. Anything on that one?
No.
Cut and dry. Saving knees.
What in your?
I don't have anything. Hold on.
Well, my brain has a process. It's lagging. It's a Friday. What in your exam told you that, like, you should have attacked the foot instead of the hip?
The first thing was when we did the half kneeling balance, and that wasn't
okay.
Yeah, and I guess first visit I said hip range of motion was normal.
Okay.
All right. So mine this week is a patient that we've seen. Well, actually, Sloan saw her a long time before I did, and then when Sloan went on her first maternity leave 3 years ago or so, I saw her for the first few times, and she had a prior to seeing, or no, she saw Sloan, then she had a cervical fusion, C6, C7. She's now 61, so she would have been 55, 56. Had a cervical fusion. Sloan didn't think she needed one. So you can kind of, she's in the medical realm. She's a surgical nurse in that realm. Came back in, had the exact same symptoms with her neck, and then finally went through treatment with Sloan. Sloan on maternity leave. I finished it off. She got a pain. So that's kind of the person we're dealing with. So she comes in June 15th. So what, 2-3 weeks ago. She comes in and she's also had constant lower level complaints of hip stuff, and then she's been diagnosed orthopedically with bilateral hip labrum tears, which we've always kind of been like, even if that's the case, you know, all that stuff. She's very, just her phenotype, very flexible, super in shape, works out all the time, single woman, very motivated by her work life, type A personality, and wanting to get out of pain so she can keep, like, living her everyday life. So she comes in and she's like, man, my hips have been worse over the past, like, 2 months. My right worse than my left. My right heel is killing me, and it gets worse throughout the day. She's a nurse, so she's on her feet. The longer I'm on my feet, the worse my foot gets. Her hip is worse going downstairs in particular. Like, that's the worst thing. Like, she says impact going downstairs. So my first question is, your back been bothering you all? No, not really. Okay, cool. So then she has a minor secondary complaint on this first day, or this first visit, of something that I saw her for a year ago. Is she fell on the ice last winter and landed on her elbow. And I only saw her once or twice. It was one of those, it was a secondary complaint because she was already in there for something. We started working on her. And then she went to PT for her shoulder. And we're going to talk about that secondarily. You and I talked about that yesterday. So anyway, she comes in and she's complaining of bilateral hip pain, has a history of, you know, a cervical fusion, and then right foot pain. So immediately, again, thinking low back, rule out the low back. This is a very flexible person. So first I'm examining the foot, go through everything. There's no positive orthopedic test, nothing really on gait that I would write home about. You can't create, there's no tenderness to touch, there's no swelling, no nothing. There's, like, your foot is normal, and you're trying to explain that to her. Even the sequelae, she wakes up in the morning, no pain. She gets walking around, it gets worse at the end of the day. But her hip isn't necessarily worse at the end of the day. She says that's worse all the time, like a deep squat. If she takes her leg up to her chest, all the stuff. And then what she has been doing is going into the gym, and she stopped like doing things like squats and lunges because it bothers her hip on the right in particular. So I go in, examine her hip. There's some positive orthopedic findings like labral scour, a little bit of pinching, but again, if you take, I don't know, 6 out of 10 people, I think you're going to have some of that. Flexion is a little bit pinchy, but she's hitting, more hip flexion than probably all of us have. And then left side, she has a little bit of pinching on full hip flexion, a little bit with labral scour, just less pain than the right. Posterior labrum shear on that right side creates pain more in her kind of SI joint posterior hip, where she's saying most of her pain is in the front of her hip. Nothing on Faye Bear. Single leg jumps, no pain, even though she says like going downstairs, like she feels like it's the impact. Anvil is negative, nothing positive neurologically, strength's all present. So then going to palpation of like her spine and everything, her low back moves amazing. So you're like, well, shit, what do you guys hear me say all the time, if you're going out from Kinsey, is there a restriction or derangement? But at the end of the day, like this lady, even though her back moves well because she's extremely flexible, she lives in extension, like top to bottom, right? Scallop T-spine, just slammed into extension all day, and then reversed her CT junction. You're wondering why she had neck surgery. So I was like, listen, it hurts to flex your knees, right? You get pinching the front of your hips. So I think lumbar flexions right there are probably out. I think seated wasn't even enough load. So I took her right to Jefferson curls, which I haven't done Jefferson curls with anybody in the past 3 years, and I'm doing it with 2 patients right now. So I explained to her why we're doing it. She can nail the floor standing on our vibe plate, which is 8 inches or something, with a 40-pound kettlebell, and just nails the floor. That's how flexible this person is. So I was like, you need load, you need exposure. And I go, I don't want to touch your foot just to prove a point, right? That we're either right or wrong. And then we worked on intra-abdominal pressure, 3-month supine, and kind of explained that a little more thoroughly, which we've went over that 10 ways of Tuesday on her neck and everything we've ever done, in particular, because again, she's cast kind of forward here because she's scalloped, and then, she's making up the difference. So getting her, back into deep neck flexion when we were working on her neck was always really tough. And she had suboccipital migraines and stuff like that. So anyway, send her home with Jefferson curls, and I say, just be aware of how you're breathing. I'm not going to say, get in 3-month supine, just do that stuff. And I think I would do 3 sets of 10 as like a part of her workout. She comes in, has almost 0 foot pain, right? She's like, it still gets worse through the day, but she's like, it's a 2 at the end of the day instead of an 8. And then she's like, I think my hip's a little bit better. And again, this is where, you may feel like you're getting your teeth kicked in, and you lay her down, full hip flexion, no pinching or pain, posterior shear, pain's gone. And I'm like, well, what's still bothering you? It's going downstairs. Okay. So now what are we working on? Now it's all central stability, 3-month supine, hammer into that. We did a little bit of DNS hanging. Said, yeah, keep up with the Jefferson curls, but now we're just going to work on how you're stabilizing around the side, because maybe you do have a labrum tear, and it's harder for you to control, even though we'd probably assume it's degenerative due to lumbar stenosis or some neurologic irritation. So work on that. She comes back in this time, and she had mentioned her shoulder at the end of the second visit. She's like, hey, by the way, are we going to address my shoulder? I go, and we had run out of time. I go, hey, this is just like flyby care. I put her in straight as prayer. I go, just work on this. Showed her the basic. I go, just work on that, and let's see what happens. She comes back in. She has like almost no hip pain, nothing. She's like, going downstairs, I still feel it a little bit at the end of the day. And then I said, hey, I think we need to incorporate some strength training, like split stance, like split squats and stuff, just to bolster, this new strategy. It's like, so let's kind of table that, and, let's look at your shoulder. So I just simply watch her do, flexion abduction kind of arc, right? She's going overhead, and you're trying to get people to touch the back of their hands together. Her shoulder blades never move. Like, they're already kind of slammed together in this military posture. And when she goes, there's no movement whatsoever. And she gets that little, like 120 degrees where you can tell she's kind of like going over either pain or something. she's like, yeah, it feels not really pain, but like a big pull on my posterior shoulder up, and I hit like 120 degrees, and then she gets past it. And again, super flexible, just like, overhead. So it's like, can you just reach as far forward as you can and do that? And she was like, oh, I don't have any pain. Like, okay. So we just worked on, I did laying on a physio ball. So she was in flexion and had her basically go through that abduction arc. Then I had her do flexion breathing, where you're hanging off a squat rack and just flexing your upper T-spine. Then I had her do bear to downward dog with like a flexion bias, like just really drive through protraction is what we're going after. And she gets up and has absolutely zero pain. And so again, what I was kind of telling Alex on that one, this one kind of as a dual, is like, make sure you roll out the low back when somebody's got stuff. She had no low back pain, right? And then you're like, well, there was nothing on palpation, in my opinion, on her back. Still had to go after affrontation just based on history. And when you have a fusion in your cervical spine, you've messed with neurology lower. It's a dynamic system. So that's, again, where the flexion bias came from. But the second thing is, I could have went down the rabbit hole of DNS, all this with her shoulder, and she had a trigger point in infraspinatus that I was paying attention to with her shoulder, but I just kind of said, well, yeah, I'm still looking at, in my mind, like, I'm looking at it as a functional audit. But what if I just she got coached into this? Because what happened here was she fell on the ice last year, basically has like a minor AC joint injury, maybe partial dislocation of her shoulder, goes to PT. Remember, she was under care with me for something. And she's just like, yeah, I fell on my shoulder really bad. I'm going to PT. I was like, okay, I'm not going to kick that hornet's nest. And what did they teach her? Scapular retraction, doing wall angels with all this stuff. Well, the funny thing is, she got better, but not perfect. And now it's getting worse because why? This is kind of the question mark in all our minds, is novelty. She did something different with her shoulder after she had an acute injury, and she got better. Now she's programmed that motor program in, which we would say is non-ideal. The non-ideal motor program is how she operates. Now she has legit shoulder pain, doing almost anything overhead. So just go back to, this is like the biomechanics conversation. Like, do they matter? Well, I think they do, because you just told her to lock her shoulder blades up, and I just had her move them around. She's like, yeah, I have zero pain. And then I just sent her home with downward dog progressions with like a protraction bias. We'll see how she responds. But I like the end of that, because again, don't get too fancy. If somebody lacks something, it's no different than if they lack T-spine extension, just give them T-spine extension. Like, don't go do 10 things or work on the secondary complaint. Mm-hmm. It'll be interesting to see how she responds, because she's also, in my opinion, not a non-responder, but she's low on that scale. So she's always kind of like, so the fact that she came in and was like, dude, my foot's like that much better, my hip's that much better, like, wow, this has to be significantly better. And then her shoulder, we'll just kind of see. But again, looking at function, in my opinion, understanding the biomechanics matter, and then just kind of making sure you're checking the boxes to rule out the lumbar spine with peripheral, issues. Also, not being afraid to, I wouldn't say think outside the box, but she had pinching in her hip. I think we'd all say, okay, we're going to do seated flexions instead of driving you into hip flexion. But I don't think that would have done a damn thing. And then I might have gotten led off track by sending her home with flexions, no response, because she's just so flexy. And she can sit there and crush her hips up to her sternum, and her low back doesn't flex at all. So just going above and beyond, I mean, okay, I think they need this. And, I guess that is kind of lateral thinking. That's my case. Any questions?
I had one earlier.
You didn't write it down in the book, did you?
No. Book's gold.
That was the problem.
Yeah.
Not really. I can think of one.
Good fun.
I'm seeing if I miss anything. No, that's it. I mean, we were adjusting mid T-spine. I guess on here I did have a trigger point soleus on that right side that I was paying attention to, which went away after the first visit.
Mm-hmm.
Did you needle it and her headache go away?
Mm-hmm.
Heck yeah.
I have had 2 cases of soleus trigger point that causes this eye joint pain. Trigger point's legit.
Yeah. I don't think I have one, but
No questions?
Mhm.
And that's only 3 visits, so she'll probably come in 2 more visits, and all the stuff will be back. 10 out of 10. We'll have to do an
Typically how it
update.
happens.
Yeah. No, she'll be pretty good. Anything else in general? If you watch these, listen to these, let us know what you want to hear. Maybe we'll do like a case write-in at some point. Like you give us a case.
Yeah.
We'll just have somebody present your case, and then we can weigh in on it. If like you've hit an inroad, or you're having a tough time, or you have a really cool case, whatever it is. Also, if there's a type of case you want to hear about, like specific diagnosis, there's certain things that are tough, but also some of the tough stuff is boring to talk about, like wrists. It's tough, but it's boring because it's like basic stuff. Like you just got to make sure you got adequate mobility and stability patterns. And it's the same thing over and over and over and over again, even though they don't respond awesome. Yeah. Anything else?
Definitely want feedback.
Yep. Cool. See you guys. Leave us a review.